Hello, good morning, good afternoon, everyone. It's great to have you
Hola,
with
buenos
us.
días,
Welcome
buenas.
to this IAS Educational Fund webinar titled HIV Prevention in Constrained Settings. Thank you so much for joining us today. So a few housekeeping rules for our webinar. Please note that due to the number of attendees, all participants are currently muted. Please note that this webinar includes interpretation in Spanish, Portuguese, and French. You can select your preferred language in the bottom bar with the globe icon. There are also live captions available. Please keep in mind that they have been generated through artificial intelligence. We have planned time for the presentation after the presentations for a Q&A session. Please send us any questions that you may have for our speakers, focusing on today's topics in the Q&A box at any time. If your question is for a specific speaker, please indicate their name when typing your question. You will notice that there is a thumbs up symbol when someone asks a question in the Q&A box. If you have a similar question or find this question important, please click on this thumbs up sign to help us prioritize the question. The recording and slides of this session will be available in IAS Plus. In case you are having any issues with Zoom, you can find additional guidance provided in the chat box. Please also send us any technical questions you may have there. In the chat box, please feel free to also let us know from which country you are connecting and what time it is for you. We love seeing some interaction in the chat. And before we move on, I would first like to introduce myself that I forgot. My name is Beatriz Greenstein. I am an infectious disease physician and researcher based at Fundação Oswaldo Cruz in Rio de Janeiro, Brazil, and I am the International AIDS Society president. I'm very proud to be here presenting this webinar and having you all with us. Before also we move on, I would also like to thank our donors, Gilead Science and Viv Healthcare, by making this webinar possible. I would also like to thank our IAS Fund team for the amazing work they do. And I would like to introduce my co-moderator, Didier Ecouvi from Togo, a friend and colleague, and we also work together in research projects. Didier, please, the floor is yours.
Merci beaucoup, Béatrice. Donc, je suis
Thank you, Beatrice,
Didier
for this
Ecouvi, je viens
presentation.
du
My name is
Togo.
Didier
Donc, je suis professeur
Ekouvi. I'm from
de santé
Togo. I'm
publique à
a
l'Université de
professor
Lomé
of public
et
health
je
at the
dirige le
University
centre de
of Lomé,
formation et de
and I
recherche
manage
en
the
santé
formation,
publique.
the
Donc,
training
ça fait plus de
center
27 ans
and
que je
the research
travaille
center in
sur
public
le
health. I
VIH
have
et
been
avec
working on
Béatrice, on est
HIV
actuellement
for
en train
27
de
years.
travailler sur
With
un essai
Beatrice,
pour
actually, we are
l'introduction
working
de
right
la
now on a
doxycycline en
test for
prévention des
introduction
infections
of
sexuellement transmissibles
doxycycline to
auprès d'une
prevent
population clé. On espère que
infectious
cette étude
disease
déroulera d'ici
sexually transmitted
2026.
on the
Voilà,
key
merci beaucoup,
population.
Béatrice.
We hope that this study will be finished by the end of 2026. Thank you,
Donc,
Beatrice.
sans vraiment
So,
plus tarder, donc nous allons commencer
without
ce
further
webinaire. Je
ado,
vais
we will
d'abord
start this webinar.
rappeler un peu les
First of all,
objectifs
I would
de ce
like to
webinaire,
remind
donc, qui est
you of the
consacré
objective of this
à la
webinar.
prévention du
It
VIH
is
dans les pays à ressources limitées. Nous sommes
it
dans un
is
contexte assez difficile, marqué
consecrated to
par
the
une réduction
HIV
importante
in
des
countries with limited
financements,
funds.
notamment
We're
les
going to talk
financements du
about the lack
PEPFAR et de
of
l'USAID. On sait
finances.
aujourd'hui que ces
We are,
changements
especially from USAID
vont
and
profondément
PEPFAR,
changer l'environnement dans
you know,
lequel
the
nous
environment will
travaillons depuis des
change
années,
quite a
notamment
bit,
les
the environment that
communautés,
we've known for
la
many
société
years.
civile et bien entendu pour
And
les
especially
professionnels de
within the
santé.
communities,
Aujourd'hui, nous
with the
allons
civil
écouter, nous avons
society,
la chance
and with the
d'avoir plusieurs
professional, the health
intervenants
professional.
venus
Today, we
d'Afrique,
have
d'Amérique
participants that
latine,
are
d'Asie et du
coming from
Moyen-Orient.
Africa, from South America, from
partagerons leur
Asia, and the
expérience,
Middle
les
East.
défis auxquels ils font
We will
face
share a
et
few
les
experiences. We will
stratégies qu'ils ont
share
mises en œuvre
challenges, and we will share also
à
the
l'adoption
strategy that have
de
been
nouvelles
implemented,
recommandations et comment nous
and
allons faire
also the
pour
adoption of
améliorer
new
la
recommendations in
mobilisation
order to
communautaire, tout en
enhance the
passant aussi, bien
mobilization
entendu,
of the
par des
community,
mécanismes de
also by
coordination et de
using
solidarité
coordination
à différents
mechanism
niveaux. Donc, nous avons
and
la chance
solidarity. So
d'avoir
today
Mohamed
we have the
Zahid
chance
de
to have
l'Égypte,
Mohamed, who
Lydis
comes from
Lopez comme
Sharif, who comes
Pérou,
from
et
Egypt. We
Magat
have Lydis from
Bosch
Peru. We
du
have Magat,
Sénégal,
who is from
et
Senegal.
Jonathan
And
Onetia
we
de
also have
Kenya,
Jonathan
Boudi,
from
Larasati de
Kenya, and we have
l'Indonésie et
Budi from
Yvette Raphaël
Indonesia,
de l'Afrique
and
du Sud.
we have Mr. Rafael from
So
South
thanks very
Africa.
much, Didier. So our first presenter, I'm very happy to introduce you, Muhammad Shahid Jamil. He is a technical officer for HIV and hepatitis at the WHO Regional Office for the Eastern Mediterranean. Muhammad will be presenting to us on HIV prevention in conservative settings, lessons from the MENA region. Muhammad, the floor is yours. You have 10 minutes. Thank you.
Thank you, Beatrice. Just bear with me. All right. I hope my slides are visible. So good morning, good afternoon, everyone. First of all, I just wanted to thank the IAS for inviting me to be part of this important webinar. So in the next few minutes, I'll give you a high-level overview of the HIV situation in the MENA region, that is Middle East and North Africa. Orient you to the policy and implementation context related to HIV prevention in the region. And I've tried to pull a few examples from our countries just to show some examples of successful implementation as well as lessons learned. So just to begin, as you know, our toolkit for prevention is quite strong and growing. So we have a suite of interventions that we can leverage and optimize for different populations, different contexts, different needs and community preferences. Obviously, I won't have time to go through all the details, but what I wanted to focus a bit on for today's presentation was harm reduction services for people who inject drugs, particularly with the focus on OAMT or opioid agonist maintenance therapy and PrEP or pre-exposure prophylaxis for key populations. But first of all, just to orient you to the HIV epidemic in the region, for those who are not familiar, these statistics that I'm presenting are in fact, they represent the WHO's Eastern Mediterranean region, which overlaps with MENA, but has additional countries such as Iran, Pakistan, and Afghanistan. So in this region, we have a rising HIV epidemic among key populations. For example, between 2015 and 2023, there was a 42% increase in the estimated number of people living with HIV. In the same period, the annual number of estimated new HIV infections nearly doubled. And AIDS-related HIV or AIDS-related deaths increased by 25%. But when it comes to the coverage of testing and treatment services, it really remains among the lowest across all WHO regions. So in 2023, only 38% of all people were diagnosed, 28% were on treatment, and 24% achieved viral suppression. So although this is increasing the testing and treatment coverage is an absolute priority, but we also need to scale up prevention efforts because of the rising number of new infections. WHO has published a series of guidelines on PrEP, starting from oral PrEP recommendation in 2015 and followed by recommendations related to different dosing regimens and more recently long-acting injectable PrEP options. as well as recommendations on post-exposure prophylaxis, with new recommendations in 2024 related to PEP, or post-exposure prophylaxis delivery in community settings, and task sharing. While we have done quite well in terms of uptake of these recommendations in national policies, represented in policies of 94% of the reporting countries, including 12 countries having policies on long-acting cabotegravir. But when it comes to the implementation, we see significant gaps. In 2023, just 3.5 million people were receiving PrEP. The representation from the region is quite minimal, and this is significantly off track from the 10 million target for 2025. Looking at PrEP policy and implementation context, from the countries where we had information available, despite the policy uptake, some of the regulations are quite restrictive. For example, 8 countries where information was available all require prescription by a doctor or a physician. And 5 countries only allowed PrEP to be delivered from treatment centers. In addition, when it comes to prioritization of populations for PrEP, 6 countries reported that they prioritize it for serodiscordant couples, where we know that the added benefit when the partner achieves viral suppression is quite limited. And in the region, we have nearly 11,000 people receiving PrEP. Similarly, for harm reduction, in several countries, needle syringe programs exist. But when it comes to opioid agonist maintenance therapy and naloxone, it's quite limited. And so a small number of countries have these programs available. Now, I wanted to now quickly switch to some of the examples that I wanted to highlight related to interesting or innovative service delivery, starting from Morocco, where they are delivering PrEP to key populations through community-based delivery models, through NGOs or CBOs that are offering integrated services for key populations, including HIV, STIs, testing, and prevention. And the PrEP is delivered by trained lay providers, which is an important approach to increase access. Importantly, there is strong community engagement in Morocco, which is somewhat unique in the region, but also, other partners, NGOs, ministries of health, and donors are well coordinated. In recent years, there's been a little bit of focus on increasing access for women, as well as in addition to men, and there has been some focused demand creation to be able to do that. In Lebanon, which is a small country, but they have both PrEP and harm reduction services available. Speaking of PrEP, the implementation started in 2022 with a small pilot project, which recruited 130 MSM delivered through the National AIDS Program. But there has been a progressive scale-up with now 3 community-based organizations involved in demand generation and service delivery. The demand is high for the size of the country. So currently they have 500 people receiving PrEP. That said, PrEP dispensation still requires authorization by a physician, so which sometimes delays enrollment of clients onto the PrEP. They have, on the harm reduction side, a needle syringe program, which offers needles from fixed sites through mobile sites and also through outreach. But the number of syringes distributed are significantly lower than the benchmarks and targets. Also, CSOs are playing a significant role in referring clients for OAMT. So nearly 2/3 of the clients are being referred from CSOs. In Egypt, the OAMT program it was established relatively recently, but it's really started with the national consultation followed by a ministerial decree, which allowed the implementation of OAMT in a phased manner, starting from establishing OAMT sites in hospitals and then going to more decentralized models, but there is a high-level committee which includes representation from ministries of health, interior, justice, to really provide that enabling environment. The program itself started in 2023, and currently they have scaled up to 20 sites across the country, enrolled more than 1,600 clients in a relatively short period. There is also a move towards allowing take-home doses. There is also some local manufacturing happen, which in the short term did lead to some, supply chain issues. But this is a good step towards sustainability. There are also part of a UNITAID project introducing long-acting buprenorphine, and further scale-up is planned as part of hepatitis sustainability plan, as Egypt being the first country globally to have achieved the gold tier on the path to hepatitis C elimination. Then moving on to Pakistan, so there is a PrEP program that was introduced in 2022. Initially, PrEP was dispensed through ART centers, but the CBOs were supporting through referral of clients after assessing their eligibility. So sometimes this would require assessing eligibility twice before the clients could be registered. And due to that, there was some underutilization. Operational research with the clients showed that in addition to stigma and discrimination in ART centers, really the HIV negative clients, they didn't want to see a physician before they can be prescribed PrEP. So this led to development and rollout of a community-based model in one of the provinces, which is a significant step towards more decentralized, differentiated service delivery. So now they have 52 sites with more than 9,000 clients enrolled in PrEP.
Un plus grand nombre.
Yeah, I think I'm getting a cue for wrap up, but this is my last slide. So I've listed some of the challenges, but also I think there are lessons that we can leverage toward the way forward. I won't go through these challenges. I referred to them during the presentation, but just to wrap up, I think progressive simplification and differentiated service delivery with enabling policy environment in a setting which is, very conservative, but also constrained in terms of funding that's available for programs. I think it's going to be really critical for expanding access to PrEP. And I just wanted to leave you with one thought that for lenacapavir, which is a new innovation, 3 of the generic manufacturers are in the region. So what could be opportunities for some of the early access in the region, and would be good to get thoughts on that as well. So with that, thank you. I have some acknowledgements here, but I will stop here and hand back to the moderators. Thank you.
Merci beaucoup, Mohamed, pour cette présentation très, très détaillée sur la prophylaxie.
Merci à vous pour votre présentation et tout ce qui était la préexposition dans la région méditerranéenne. Oh, pardon. Yeah, we're going to continue this webinar. We are going to start with the first panel, and we're going to talk about the different regional perspectives in different countries. We're going to talk about the prevention of the HIV, and we're going to talk about this crisis situation. We have many panelists who are connected to this call. And to start, I'm going to ask Lidice to start with her presentation. She's from Peru, and we have questions for her. Lidice is here. She's connected. Well, our first question, how is the recent reduction of finance of funds have had an impact on civil society in Latin America? And how do you mobilize a bit more funds in order to maintain these programs of prevention of HIV, especially for key population? what
la
is the
solidarité
role of
régionale pour
solidarity
la
at the
poursuite de ces
regional
efforts de
level in
mobilisation
order
des
to
financements.
pursue the
Lydie,
efforts
tu as
of
la
finding
parole. Merci beaucoup.
funding? Lydis, go ahead.
Tiene la palabra.
The role of civil society and the communities in the response to HIV in Latin America has been present forever through legal suits, political advocacy for countries to receive and contribute funds to buy ARTs, as well as through the consolidation of these programs by identifying bottlenecks and to transition towards the public system by exercising pressure on governments to ensure acquisitions and the necessary budget to maintain these services. As you may know, today almost 90% of countries fund ARTs in our region, and civil society organizations apparently are paying the price of this success because they're getting fewer resources for their operations. For decades, the civil society has been supporting programs for the youth, fighting for a human rights environment that will protect LGBT people so they will get closer to these health organizations to have a healthy life, a pleasurable sexual life. And we've always been doing a lot with very few resources. Over the last few years, many civil society organizations made up of people living with HIV or LGBT people. These organizations have been providing services, ARTs, and PrEP services, surveying timely implementation, right implementation, and stigma and discrimination, facing stigma and discrimination situations. According to the information we collected in February and March, out of 18 countries, half of the people who filled in a survey had to close their institutions or reduce the delivery of their services, leaving young people, pregnant women, indigenous populations, migrants, people living with HIV, and other key populations without any access to these services. And many of these organizations have been having difficulties to access alternative funding or emergency funding that will help them maintain the services they provide. Now, talking about PrEP specifically, the impact has been quite significant. We know that in Colombian, Ecuadorian, and Peruvian organizations, delivery of PrEP services have been stopped fully because they had been funded through resources provided by PEPFAR. And all organizations are saying that should services be provided again, they will have trouble working with gay and trans people in Honduras and Peru, as well as in the Dominican Republic. The support provided from the US has stopped, and so they're having difficulties to meet the needs of key populations. I also believe that this is a specifically an especially serious situation because this was a time when many countries were adopting PrEP strategies, and not out of the blue, but because there were civil society organizations that were working hard and doing advocacy. We hope that this will not lead to growing incidents in the next few years, but this is yet to be seen. It's important to point out that since many activities provided by civil society also depend on PEPFAR and on the fund to fight AIDS, malaria, and tuberculosis, we're now seeing a gap. The World Fund has also stopped some activities. Even though Latin America only accounts for 4% of the World Fund portfolio, the grants have always been catalysts for the work done
with key populations, and they've always made it possible for the civil society and the communities to be on an equal footing with other governmental organizations to create public policies in the health environment. Even though the interruption of healthcare services have a huge impact on human rights, I should also say that organizations in key populations are facing in our countries a concept of homophobic violence. Many of us have been working very hard, and our work has been weakened because of a lack of resources, and this may lead to increasing violence against key population. Those who have been mostly harmed by attacks from the US, whether directly or through the World Fund, are the key populations, and we have to say this loud and clear. But the second question was, what are we doing to face this situation? Civil community-based organizations are sharing accurate information. We are speaking out and saying what's happening with these budget funds, and we have to communicate what the result of these decisions are. And we're also sharing strategic information about donations or alternative donors, other possibilities, and especially strategies to move forward with our countries so that our countries can face their commitments to fund the services that are no longer funded. This is still ongoing work, but we have to work together to define what the developments will be. Thank you very much for your attention.
Merci beaucoup, Lydie, pour ce témoignage, pour ce partage d'expériences.
Thank you, Lydis,
Et
for
beaucoup de
this
courage à vous.
testimony, for
Donc, je vais
sharing all
laisser la
this
parole à
experience,
Béatrice
and I
pour
wish you
continuer
all the best. And I'm
panel.
going to
Merci
give the floor
beaucoup,
to
Lydie.
Beatrice for her to continue with the
Thanks
panel.
so much, Didier. Thanks, Lydis. I think it was a really good presentation on our region. As we heard before with Mohammed, in Latin America also PrEP scale up has been very slow, and we are one of the few regions where new HIV infections have been increasing in the last 15 years. So all news that you brought us are very concerning. And we do hope we have support from the local countries to move forward with the implementation of PrEP and our other prevention measures. So thank you really very much for your contribution. So I would now like to ask Magat Mboj, Executive Director of the National Alliance of Communities for Health, the ANCS in Senegal. And I would like to pose you a specific question. So can you share specific examples on how HIV prevention programming has been restructured at the community level in Senegal following USAID funding cuts? And what lessons have emerged about building resilience in service delivery? Magat, the floor is yours. You have 5 minutes.
Merci beaucoup.
Thank you
Je
so
crois
much,
que je ne
everyone.
reviendrai pas en profondeur
I don't think I will
sur
come
peut-être
back in
l'impact
detail
des
on
coupes
the
budgétaires sur
impact
la prévention du
of
VIH
the
au
lack
Sénégal,
of funds
parce que
for
tout à l'heure on l'a évoqué,
HIV
ça a eu
prevention
des
in
impacts
Senegal. We
sur
talked about it. It had an impact on
la mise en
the
œuvre de la PrEP. Parce que
implementation of
comme vous le
PrEP.
savez, le Sénégal fait
As you
partie
know,
des pays de
Senegal
l'Afrique
is
de
part
l'Ouest
of
qui
the
ont
Western
un taux de
countries of
prévalence
Africa who have a prevalence rate
très
of
ciblé
that is very targeted, sorry.
Une épidémie de type concentré
It's a
vers
concentrated
les populations clés
epidemic
qui sont
on
les
the key
consommateurs de
population.
drogue
They are
injectables,
the
les hommes qui ont des
consumers
relations
of
sexuelles
drug,
avec d'autres hommes, mais
the
également les professionnels du sexe. Et
H,
l'essentiel des interventions que
the
nous menons,
professional
que
of
le
sex
gouvernement,
sex
les acteurs
workers,
de la
sorry,
société
and
civile
men who
mènent
have sex with
sont
other
des
men.
interventions
The
dirigées vers
government,
cette
the
population.
actors of
Et
social
donc, ce sont des
security
interventions de prévention, mais
have
également des
intervened to
interventions
prevent
de prise en charge et de traitement. Et donc,
those
lorsque les coupes ont surgi, je vous dis,
preventive
je pèse bien mes mots,
measures and
lorsque
treatment
un
measures.
matin on a su qu'il fallait
These are
couper,
preventive
donc,
intervention, but also
il y a eu
management and
un
treatment
impact
intervention.
sur
When
l'offre de
cuts
services
appear, I wait
différenciés,
my word
un
carefully.
impact
When
sur les
it was
acteurs qui
clear
faisaient
that they needed
l'offre
to
de
be,
services, c'est-à-dire
so
le
there was an
licenciement
impact of the
de plus de
provision of
47% des
differentiated
ressources humaines
services.
ici au
There was an
Sénégal.
impact
Et
on
c'est
the
pareil
actors who
dans la
offered
sous-région,
services,
avec le
namely
Mali, la Côte
layoff,
d'Ivoire
more
et
than
tous les autres pays
47%
comme le
in
Togo,
Senegal. It's the
etc.
same in the
Et que cet
sub-region with
impact-là,
Mali
les
and
acteurs
Ivory
communautaires
Coast
qui
and all the
assuraient
countries like
en tout
Togo,
cas l'offre de
etc.
services
And this
au niveau
impact was due
communautaire
to
ont
community
senti
actors who were, in any case,
un arrêt brusque
providing
de leurs
services
interventions. Ce
at
sont
the
des médiateurs
community level.
communautaires,
They
ce sont des
felt a
pères
sudden
éducateurs
halt
qui
to their
ont
intervention. They are
ont
community
arrêté de
mediators,
fonctionnement.
father
Il y a eu
educators, as
un
we
impact
call
sur
them,
la
and
dotation
the
même vu du mois
operation was
des ARV.
stopped. There was
Mais
a
par
lot of
rapport à tout
impact on
cela,
funding,
par rapport,
on the
et en plus
ERVs,
de cela, il y a eu une
on the
fragilisation
staffing. But compared
progressive de
to
la
all
réponse,
this,
surtout
there
dans les
has
zones
been a
à
weakening
concentration élevée
also
du
of
VIH.
the progressive
Un
response,
risque
especially in
élevé de
areas with
dislocation
very
aussi
high
des
HIV
organisations de
concentration.
population clé. Parce que
There was a
pour
high risk of
agir au niveau de
dislocation
ces
for
structures,
organization and key
de ces
population.
organisations, on
In
les
order
avait
to
déjà
act at the
organisées en
level of
groupes
these structures
bien
and organization,
organisés
we
pour
had
pouvoir
already
agir, pour pouvoir
organized
travailler avec eux. Mais
groups
malheureusement, avec ces ruptures,
in order to act
nous
and
avons
work
vu
with
que
this population.
les
But
groupes s'effritent
unfortunately, with
de
this
plus en plus.
breakup,
S'effritent
we have
et
seen
je rappelle que la
this
coupe est arrivée au moment où
we have
dans
we
la
have seen that these groups are
sous-région, et
falling apart more and
particulièrement au
more.
Sénégal, il y a des
Um,
menaces
in Senegal,
de
in that
criminalisation,
sub-regions,
des
they
menaces
are
de violation des
threatened
droits
by
humains. Donc,
by
pour vous
crime.
dire que
There's
c'est un
crime, there are
environnement
threats of
où
human rights
les
violation.
coupes budgétaires
So to
frôlent
tell you
avec
this in an
un
environment
environnement qui n'est pas
where
des meilleurs,
the
même pour
budget
développer des
cuts are
interventions à
present,
direction de ces groupes.
this
Mais comme
environment is not
la société civile est toujours avant-gardiste,
positive for
la société
developing
civile, c'est vrai que
intervention
cette
targeted at
décision de
this
couper
particular
nous a
group. But
surpris, a
when
surpris tous les
civil
acteurs,
society
mais
is
aussi
always at the
nous a
forefront,
permis
it's
de
true that
commencer
this
à
decision
agir
to
vite
shut
fait.
down surprised
Et
us
qu'est-ce qu'on
because
a
of all
fait
the
sur le court
stakeholders.
terme?
They started
Lorsqu'on nous avait
acting quickly
demandé
and well.
de
What did we
couper
do
certaines choses,
in
ce
the
qu'on
short
a fait,
term? We
c'est
had been told
véritablement,
to
en
cut
tant
the
qu'acteur
budget.
de la société
So
civile,
what we did,
voir
we
tous les moyens pour assurer la
we
continuité
found
des
all the
traitements
means
et de
possible
l'accès
for
aux
the
soins.
social
Et en faisant quoi?
society to
En
continue with
procédant
treatment
d'abord
and have access to
à
care.
la repriorisation
And
des activités
we
pour centrer
prioritized
les
some
interventions
activities.
sur des services
We
essentiels.
centered the
Ce travail, nous
intervention
l'avons
on
fait
essential
en
services.
concertation avec
We
l'ensemble des acteurs
worked
communautaires.
while
En
collaborating
plus,
with community
nous avons
stakeholders.
essayé de voir dans nos
Also,
stratégies
we
comment
tried
renforcer
to put together a
l'intégration
new
des services
strategy to enhance
au niveau
service
communautaire,
integration
que les
at a
services soient
community
intégrés
level. So
VIH,
these services might
tuberculose,
be
hépatite,
integrated,
IST,
anything
et
that
même
is
santé de
linked
la
to
reproduction, on est
HIV,
en train de
hepatitis,
voir dans
tuberculosis,
l'immédiat
etc.,
comment les
hepatitis
intégrer
C,
avec le peu
um,
de moyens que nous
reproductive
disposons,
health.
comment intégrer
We're
l'offre de
working on
services
how to
au niveau
integrate all
communautaire.
these services.
Mais
We have
également,
limited resources,
nous
but we
avons
can integrate
procédé à
service
des relances
provision
parce
at the
que
community level. We
il y a
try.
plusieurs acteurs
But
communautaires qui ont cessé d'agir. Et ces acteurs
we've
avaient pour
conducted
rôle
relaunch
non
efforts
seulement
because
d'aider
several
les sites de prise
community
en charge
actors have
dans
stopped acting. And if
l'aide
these
au
actors,
traitement, dans l'observance au
they have
traitement,
a
il
role
fallait
that
que
is
ces
just not
acteurs, les
only
acteurs,
to
on les
help the care
remobilise
sites,
pour
but
faire les relances
to help
au
us
niveau des
be
sites.
compliant
Pour
in
que,
treatment.
pour
These
aussi
actors
qu'on ne
these
perde
actors
pas
needed to
ce
be
lien entre
re-engaged to make progress
le
at this
site
level,
et les
at this
malades.
level, so we
Et
don't
en plus de
lose.
cela, nous avons
There is a
actionné
link between the
également
site and the
tous les
patients.
acteurs qui
We
travaillaient
took
sur
action
le
with
CLM, c'est-à-dire
stakeholders who worked with the CLM. CLM is the supervision of the community-led movement or activities. We had to do this so there's no threat of drug stockpiling. In addition to continuity of treatment, access to care, we had to prioritize the high impact intervention and conduct a comprehensive review of our departmental budgeting. To date, the financiers are working closely with the programs. And so we had to review the streamlining of operation. My predecessor mentioned this earlier. The Global Fund asked us to do that exercise because it was a principal, ANSES was a principal recipient of the Global Fund since 2005. So they asked us to review our activities at the community level and to review the budgeting in terms of time, in terms of unit cost, but also in terms of frequency and format. In terms of format, we are currently looking at how to do it and promote the use of digitalization. Because today there are platforms that are useful, but we have to rationalize resources by removing some operating courses. Sometimes we have to supervise some information. We have to check all that information because that information cannot always be eliminated. In short term, there has been a reorganization of work. The community actors are reorganizing. They're working with governments, local elected officials, and in short term, long term, they're meeting with parliamentarians to explain the consequences of budget cuts on HIV prevention, in particularly and specifically about screening, follow-up care, distribution of HIV, ARV. We talked in that matter. We talk with groups and community who are truly involved. Local elected officials can support civil society actors in that matter. We want to ensure the sustainability of intervention, but also the different organizations. The community intervention are community-led, and they depend of external funding. So we want to work at long term. And we want to fix the problem permanently. And how to correct the situation would require more than just strengthening advocacy. We have to contact the authorities to have access to financing. But we also need them as we need all these people as civil society actors. We can optimize our resources. How do we optimize them? The first thing is to move beyond the project logic and think about a global organizational model. Virtually all civil society organization, whether that is Togo or Benin. In Senegal, Ivory Coast, and Mali, there are organizations who simply live because they have funding to run programs. The day these programs stop, the organization cease to exist, and that's what's going to happen. We need to correct the way we do things. We must restructure the business model of this organization. We need to redefine the business model organization through revenue diversification. Civil society organizations should be able to provide marketable services. And we should be able to raise the society should be able to those enterprises should raise equity and develop strategies with philanthropists the operating costs of this organization should indeed be reduced, restructured. We should restructure human resources, but also have professionals who are versatile in their job. The staff should be sufficiently equipped to handle a reduced number of employees, but with the multifaceted skill set, of course. We have to rethink all this. The way to collaborate with government organizations must be rethought as well. With the private sector, we should be able to sign social contracts in order to put together goals that can be achieved, but also be remunerated accordingly. So we have to talk about adapting coping strategies at medium and short term. We need to support engagement and mobilization of community. And we have to encourage mentoring and coaching of community workers. We need to put together new digital approaches to prevent, in order to have prevention for the general population, more specifically the groups that are vulnerable. With this, all the partners are asking us to stop encouraging training, but we are suspending training for now. But we went through the COVID period when we had suspended intervention, but we hadn't stopped implementing it. And I think that today, this is the big lesson we have learned from our experience. We were resilient during COVID. We have to do things differently. We need to do things differently. We need to continue training without having to do them on site. That way we don't have to reimburse transportation fees or travel costs, expenses, etc. If we do it, if we go there, because we need to learn, we have to change the paradigms, but we can't expect that some details in the organizations will remain the same. The experience of today will tell us that we can act differently and have the same results. We are trying to do that. We need new approaches, and we need to take into account that we can use the digital world. We have tools now, digital tools that everybody uses, that are this women, children, sex workers, everyone, trans, all kinds of people use it. We need to use that. We need to reinforce the data on the platforms that are linked to prevention and are dedicated to vulnerable groups. We need to promote the knowledge management when it comes to stakeholders, community stakeholders. We need to give value. We need to enhance the knowledge. We need to develop innovative approaches to prevention, but also ensure efficiencies of intervention. We really need to act differently. And to add my message, I would like to send a call for action. Stakeholders, community stakeholders, that they are in Africa, in America, in Europe, anywhere in the world, they have had to be mobilized at the very beginning of epidemic periods. In West Africa, we engaged, we raised awareness and trained. We had to transport sick people with carts. We had to distribute ARV with bicycles and motorcycles, and we won. And we also made sure that we had access, everyone had access to treatment and health service without exclusion, especially for those who need them the most. Our commitment will always remain or always prevail. Thank you very much.
Merci beaucoup, Magat, pour ton cri de cœur.
Thank you,
Et
Magat, for your
merci pour le
heart,
partage de
your
l'expérience
call
du
to action from
Sénégal
your
qui
heart.
reflète celle de
Thank you
toute
for the
l'Afrique
participation
de
of
l'Ouest. Merci
Senegal,
également,
who's done
merci
so
tout à
much
l'heure
in
pour l'introduction
West Africa.
de notre
And
effectivement
thank
qui
you
a cette
also
coupe
to
budgétaire
Beatrice
violente
Puchener for
qu'on
her
observe au niveau des
introduction.
différents acteurs
Noted
communautaires,
we
mais
talked
sans
about the
acteurs
severe
communautaires,
budget cut,
il
and
n'y a
we
pas
have
de lutte
observed
contre
that there is a
le
level of
VIH.
various community actors, but without
Nous
any
allons
specific
probablement aller sur,
community actors.
vers
There's no
l'Afrique
fight against
l'Est
HIV.
pour voir
We
peut-être
will
que si la situation
go
est
to
meilleure
East
ou bien
Africa.
moins
Maybe
catastrophique
the
dans cette
situation is
région
better
de
there or less
l'Afrique avec des niveaux
catastrophic
de prévalence plus
when it
élevés.
comes
Et
to
nous avons le plaisir d'accueillir
in this
maintenant
region of
Jonah
Africa with high
Anetian,
prevalence
qui est le
levels. So
responsable de la
we are pleased to now
prévention
welcome
au
Jonah
niveau du
Anetian, who
Programme
is
national de lutte contre le
in
sida et les
charge
infections
of
sexuellement
prevention at the
transmissibles
National AIDS and
du
Infection
Kenya.
Control Program level
Jonah Anetian, tu as
of
la parole
sexually
pour 5
transmitted
minutes. Et mes deux
infection
questions,
disease
c'est
from
on
Kenya.
voudrait
Again,
savoir si d'un point de
2
vue
questions.
gouvernemental, comment
From
le
a
Kenya
government
s'organise
perspective, how
pour
is Kenya
maintenir ces
working to
priorités
safeguard
nationales
national
en matière de
HIV prevention
prévention du
priorities
VIH face
amid
à l'évolution des bailleurs?
shifting
Et puis
donor
deuxièmement,
landscapes,
si tu peux
and
nous dire
what
quelles stratégies sont mises
strategies are
en
being
place
employed
pour
to
renforcer le
strengthen
financement
domestic
domestique
financing
et
and
la coordination
coordination,
nationale. Merci
national
beaucoup, Jonah, tu as
coordination.
la parole.
Thank you,
Pour 5
Jonah. You
minutes,
have
s'il te
the
plaît.
floor for 5 minutes.
Kindly confirm that you can hear me. Kindly confirm you can hear me.
We can hear you. Thank you. Yes, we could hear you, Jonah. Thank you. Please go ahead.
Yeah, thank you. I want to thank you once again for the opportunity to share on this subject matter. Probably I'll start with the HIV 2023 estimate in terms of the epidemiology. The epidemics, as in the national HIV prevalence, is about 3.7%, and we have about 1.4 million people living with HIV AIDS. And out of that, we have about slightly above 22,000 new HIV infections, of which about 41% of them are contributed by the AYP. Now, the US government stop work order that was implemented in January 2025 has significantly disrupted the HIV prevention services, including PrEP, AYP, and key populations. The directive altered US foreign assistance programs, particularly those under PEPFAR, which have been pivotal in supporting Kenya's HIV prevention response. In terms of the service interruptions, we saw some organizations which provided prevention programs and related HIV services being forced to suspend operations. And these are really affected thousands of individuals, especially among the key populations who relied on the services that these particular organizations were offering. And interruptions of the new HIV testing services, it caught us in the process of shifting from 2-test to the 3-test algorithm. And the stop work order meant that some of the scheduled trainings were canceled, and therefore, without testings, most of the prevention or uptake of the prevention services was also affected. In terms of the PrEP commodities the guidance, we remember that the waiver providing the guidance that the commodities procured through PEPFAR through the US government funding could only be used by the pregnant and breastfeeding women. And this led to discontinuation of PrEP for some time of the other population typologies. And though the Kenya treatment and prevention guidelines indicate that PrEP should be offered to all populations who are at ongoing risk. And in terms of the human resources for health, there was a significant displacement, about 41,000 workers across Kenya who are funded by the PEPFAR were also affected by the stop work order, though temporarily. And this also affected the output, leading to job suspensions. And also in terms of interruption of service delivery, we saw that the peer-led models of service delivery used to reach the AYP vulnerable population, and the key population was also affected. And these population subtypologies were meant that they had to collect their medications or commodities at the health facilities, where now they had to pay consultation fees or queue for services, and some who are not pregnant were also denied prevention services. And not to mention the loss of the technical expertise. In terms of the procurement and distribution of commodities, our commodities procuring system also recognizes that we have the MEDs who are responsible for the procurement of commodities procured through the funds of the US government. And so there was a temporary destabilization of the supply chain. So these are the disruptions that have affected prevention services within the country. And in terms of the strategies to safeguard the HIV prevention priorities, which for us is to ensure that all who are eligible for a prevention mode or the other get the service amid the shifting donor landscape. The first step was to do a situational analysis so that to determine the magnitude of the impact the stop work order had on the prevention services. And then secondly, working with the national and the regional TWGs and using the evidence from the various research projects focusing on the simplification of the PrEP delivery through the review of the HIV, hepatitis, and syphilis prevention treatment guidelines. And also in terms of integration of PrEP services as a priority of the national PrEP program and has long been included in the guidelines. So this is something that we are fostering on in terms of integration. And the national program has described 3 models of integration, where we have either the one-stop shop, we have the supermarket model, and also the referral model. And PrEP has been integrated in the combination prevention package of service as an additional biomedical choice, and additionally has been integrated as a service offered with other clinical services. Then the various components of PrEP have also been integrated in the various or the different service delivery points. For example, the screening of the ongoing at risk or those who are ongoing risk of HIV infection has been implemented in almost all service delivery points by both the clinical and lay providers, and also clinical consultations by clinicians in different service delivery points. We have also had a situation whereby we have the clinicians working in the CCC or HIV service delivery points, working in a rotational manner so that they move from the other service delivery points within the hospital, coming to work at CCC in a rotational form. And also when the stop work order issued the guidance on provision of PrEP to only the pregnant and breastfeeding women, what the country did was to issue a circular on service delivery, providing guidance that PrEP to be used by all HIV negative individuals who are at ongoing risk of HIV, and additionally provided the PrEP commodities, and so that everyone who is at risk can be able to get the services. And also riding on the national campaigns, such as the triple elimination, where PrEP contributes to one of the pillars, we've been able to ride on those national campaigns so that we can be able to, one, advocate for PrEP and also pass on the messages of PrEP so that it runs on the national campaign pillar. I've mentioned that testing was also affected, and therefore to mitigate against this, most of the counties, because in Kenya, most of in fact, the health is a devolved function where service delivery has been devolved to the lower units and policy making has been left at the national level. So most of the counties, to enhance service delivery, especially when it comes to testing and also the roll down of the 3-test algorithm, most of the counties have shifted to on-job and mentorship so that they can be able to get most of the healthcare workers trained on the 3-test algorithm, so that they can be able to quickly address the testing and gaps. And one other thing that we're looking at is the engagement of increasing the access and to increase one of the things that was done was to a cabinet memo, which and request for funding through the supplementary funding, because this came at a point where we were in the middle of a financial cycle. The only thing that we could opt for is additional funding from the additional or the funding that comes in the middle of the financial cycle. So we were able to do a memo which went with a budget to cabinet so that they could be able to approve some funding or additional funding supplementary budget. And then some of the counties are also employing some of the healthcare workers who are supported by implementing partners so that we can be able to ensure there is continued service delivery. And then advocacy for allocation of domestic resources is an ongoing process. So we hope that we are going to get additional funding in the coming budget that will be read in July. Thank you, and I wish to pass it over to the moderators. Thank you.
Merci beaucoup, Jonah, pour ton partage d'expérience et pour
Thank you, Jonah, for sharing your experience and to explain all that you are trying to do in Kenya in order to face all this whole crisis. Now I will share the floor with Beatrice.
Thank you so much, Didier. Jonah, that was a terrific presentation. Thanks very much for all your efforts and for the great summary that you provided. It's really very important for us to hear how countries are taking ownership and leadership to deal with this major crisis, and it's really good to hear that options are being tried and that part of the world is being incorporated by the governments. As we all know, that communities were the most affected, as major funding lines were provided by the US government to fund community work. And as a result of that, key populations are obviously the most affected, as most of the services for key populations are provided by peers and community-led organizations. So thank you very much for your presentation. I would now like to ask Budi Larasati, changing gears to Asia. Budi is the project officer at Indonesia AIDS Coalition. and we are very happy to have you with us. And the question that we would like you to comment on is, how has the funding crisis in Southeast Asia acted as a catalyst for innovation in HIV prevention approaches? And what are some standout examples of low resource or community-driven innovations that have emerged so far? Buddy, the floor is yours for 5 minutes now. Thank you.
Okay, thank you, Beatrice. Before I start talking about PrEP in Indonesia, I would like to start with the context. As of August 2024, there are approximately 503,000 PLHIVs in Indonesia. It's not much, but we rank 13 globally for the total number of PLHIVs, and also 8 in new infections. We are still far from reaching the triple 95 target, especially for access to ARV and also for viral suppression. In summary, the HIV program in Indonesia have diversified funding sources with a mix of the national budget and also from international donors. For instance, testing kits and ARVs are funded by the national budget. However, things like OFTs, condom, sterile needle and syringe programs, and also PrEP are funded by international donors, most notably the Global Fund. Global Fund is our largest donor, which allocates around 103 million USD for the 2024 and 2026. As has been previously mentioned, as a result of the funding crisis, the Global Fund is working with its partner countries, including in Indonesia, to carry out readjustment efforts, focusing on life-saving activities and aiming for a 50% budget saving. This readjustment process is still ongoing in Indonesia and will continue until June 2025. My organization, the Indonesia AIDS Coalition, is one of the Global Fund's community principal recipients in Indonesia. We implement the HIV prevention for female sex workers, addressing human rights-related barriers on access to health services, and also community system strengthening modular. Overall, IEC operates in 140 districts with approximately 540 field workers. Our field workers refer clients to access PrEP at public health centers, or in Indonesia, we call it puskesmas. The PrEP use is a combination of TDF and FTC because new generation such as cabotegravir, etc., is not yet available in Indonesia. And from January to May 2025, there were approximately 20,000 referrals to the puskesmas. If a client is willing to go to the puskesmas, they will undergo screening to determine their eligibility to access PrEP. And PrEP is still relatively new in Indonesia. In 2024, PrEP is available in 95 districts, and it expands to 35 more districts in 2025, and hopefully 30 more in 2026. And the uptake is still quite low. Most notably, it's due to stigma and discrimination. Funding cuts have also affected training costs for puskesmas workers to implement this new PrEP program, and also the cost for logistic distribution. Such as the general overview of PrEP provision in Indonesia. However, we would like to use this opportunity to emphasize regarding the importance of a comprehensive approach for HIV response, especially in Indonesia, because we cannot focus solely on service delivery. Creating an enabling environment is important because stigma and discrimination is still rampant, as proven by the 2024 Stigma Index released by the Positive Indonesia Network and also the 2023 IBBS report. stigma, especially against PLHIV and key populations, is still a problem here in Indonesia. And it prevents them to access not only health but also other public services. So it is not enough to provide commodities in the commodities in healthcare services, but key population must also be aware of them and also feel safe in accessing those services. However, unfortunately, our human rights program, which focus heavily on advocacy, lobbying, campaigning, and sensitization, are questions regarding its life are not classified as life-saving, but stigma and discrimination hinder access to health and public services in Indonesia. So this is why we believe that a holistic approach for HIV programming is needed. So to answer your question, this is a very recent development in Indonesia. And we're still on the process of readjustment, etc. Because as I previously mentioned, our biggest donor, the one that supplies us with PrEP, is asking for readjustment. So we're still doing that. But what I can say is that stigma and discrimination is a very real problem in Indonesia, and it hinders people to access PrEP and ERVs and other services provided in the health centers. That's all from me. I hope I have conveyed the information clearly, and I'll return the focus back to the moderator. Thank you.
Thank you very much, Woody. It's really good to hear from you and the challenges that are ongoing in Indonesia, although a lot has been done. And I would like now to pass to Didier so that he can move with our next panelist.
Merci beaucoup, Béatrice.
Thank you very much, Beatrice. The next panelist will be Yvette Rafaela with us. She's with us this afternoon. And she will talk to us about South Africa. Yvette Rafael is Executive Director of Advocates for the Prevention of HIV in Africa, in South Africa. I have two small questions for her. Maybe she can answer in 5 minutes. Okay, with HIV prevention research in South Africa impacted by recent US funding cuts, what are the most pressing challenges now facing the research community, and how are researchers, advocates working to adapt research priorities, partnership, or funding strategy to sustain progress? Yvette, now you have the floor for 5 minutes. Thank you.
Good afternoon, everyone, and thank you so much, IAS, for inviting me to be on this panel this afternoon, and also for the question. I think for the interest of, because time, I would just like to give some few of my thoughts around the questions that I asked. And I think just reiterating what some of the panelists said, and I heard clearly some from Senegal saying, do not stop. When we stop the work, we likely to lose some traction. And also the issue around communities. What we cannot do this without a community. So as mentioned, my name is Yvette Rafael, and thanks for inviting me. HIV prevention research. Most of the time when we speak about this, we only focus on HIV prevention, but we need to understand that treatment research has stopped, vaccine research has stopped. So basically, the hardest hit in this current situation for us in South Africa, but also globally, is the stopping of research for prevention treatment as well as vaccines globally. But we know that it is all part of the bigger picture, major projects closed in South Africa, like the Brilliant Project, Matrix and Ayavi. I know they are going through the worst times. Southern Africa is still struggling with the number of young people getting infected with HIV. So the prevalence rates for young girls, adolescent girls and young women has not been able to come down. But we know that we've made major strides, and I think Mohammed said that in his opening presentation. We've made major strides with regards to getting the toolbox to actually answer some of our questions. And now we find ourselves in the situation that we are in. But also just to mention that Southern Africa and South Africa is not only the burden of HIV and, new infections that is problematic, but we also a major role player in the research and development space. A lot of HIV research happens in Southern Africa and South Africa specifically, and you can just imagine with the focus being on the funding cuts for South Africa. In South Africa, most of our research sites have suffered immensely. The task is daunting. How will we have these projects continue with such major cuts? And what makes it difficult for us to navigate is also not only the money, but ethically what happens. What happened is very wrong. When we woke up the next day, some of the sites were closed, and some participants found themselves without research product or with research product that they could not explain on a way forward. Countries have laws around research and ethics, and that we are governed by that as well. So not only is there a problem with funding, but ethically there is a huge problem, and we have not even started to speak about how unethical that the funding cuts were. Stories of young people, like I mentioned, without the research product, and we have to be concerned about the future of HIV prevention and research, especially in South Africa, where so much of the research happens. Is how are we going to continue after the madness is gone? After all of this, some people are saying 4 years, but how are we going to continue to build trust, not only for research that comes from that are donor funded or come from the north, but also how do we build trust with the research space itself? We know that it is important for us to remember also that most of the research, most of the people are still worried about research and are dealing with anti-vaxxers. But how are we going to deal with that after this period is gone? And that is important why we are fighting for our research projects not to stop. We are fighting for the research agenda and HIV prevention agenda to continue. We want to ensure that we do not stop the work, so that once this is over, we are able to continue with the work. I think due to time, and also as you can hear, I have a horrible flu. I would like to stop here, and I'll take other questions if they do come up in the Q&A area. Thank you so much, Didier.
Merci beaucoup. Merci Yvette Raphaël, vraiment d'avoir insisté
Merci,
sur
Madame Raphaël, d'avoir
les
insisté.
difficultés
Oh,
liées à la
thank you,
recherche
Mrs.
qui doit être
Raphael,
stoppée dans
to
ces
have
temps de
insisted
crise
of the
sur la
difficulties
prévention.
for
Et aussi,
research.
profiter de
The time has
l'occasion pour
stopped
vous
for prevention.
remercier
So
pour tout
we
ce que vous
want
faites
to
dans la
take the
lutte contre
opportunity
l'infection
to
à VIH dans votre
thank
pays
you
au-delà
in your battle against
le continent
the
africain. Merci beaucoup.
HIV in the on the African continent. Beatrice, you can take the floor now.
Merci, Didier. Thank you very much to all the panelists. That has been an amazing hour hearing all of your experiences. Thanks, Muhammad, for joining back, Lidis, and Woody, everyone. And thanks, Solange. And thanks, Yvette, as well. Despite your flu, you gave an excellent speech, and we are very happy to have all of you in our panel. So it is very sobering to hear what is going on across all regions. but it's reassuring to see and hear that in all places there is commitment, hopefully, to move forward. And I believe that solutions can be found when country leadership has the political will to move forward despite the severity of the cuts. We need to be resilient and move forward. So we would like now to move into the question and answer. So I would like to first start with a question to Lidice. It was really great to hear from you about our region, and as you mentioned, scale up of PrEP in Latin America has been very slow, and in many countries, most activities for the community have been financed by external resources. So with these major cuts, I would really like to hear from you that how do you envision the sustainability of the actions that need to be taken to make this prevention agenda to move forward in the region? For instance, Dominican Republic has been an example for us on how to implement PrEP for key populations. And also your country, Peru, has improved PrEP access lately, but we know that everything is in danger. So I would like to hear a few words from you on how do you envision the work on sustainability. And I would then like to ask if all the panelists could also contribute with this vision on the longer term sustainability. Thank you.
Thank you, Beatriz, for your question. The strategy, the main strategy which we are using at the communities and civil society organizations is to exercise pressure on the governments to take up or to provide the funding for all the PrEP services. In Peru, we have made progress here with the getting funding from the administration. We still face some issues to reach more cities or more people, but we believe that this is the government's responsibility, and this is where we are focusing our efforts on. We do know that in other countries, as you said, the Dominican Republic, Honduras, maybe Guatemala, there is more reliance on external funding, but they are making the transition towards domestic funding by their local governments. Anyway, some resources, even small resources, are necessary for civil society organizations to do advocacy vis-a-vis their governments, because this doesn't happen overnight. There is not so much political willingness as we have seen in other countries, where after the funding limitation, local governments have quickly taken up or started providing funding for PrEP services. But in a nutshell, I believe we are exercising pressure on the government so that they strengthen and take up health care services. Thank you very much, Lidice.
On your side, from your region, please.
Sorry, who was the question for?
Oh, I would like, the question was about sustainability of
No,
the
so that
action.
was directed to me. Sorry, I missed the part. It was overlapping with interpretation.
No, I'm sorry. No, I'm
right.
sorry. I
No.
asked in the beginning for legitimacy and wanted to hear from you all, the
Yeah.
panelists, and I started by you after her,
Thank you.
about the sustainability of the response of from the countries to the cuts, and how do you
Okay.
envision this sustainability moving forward for your region? Thank you.
Sure. Thank you. No, that's clear. So maybe I just wanted to add before I respond a little bit of a context to the region of like of MENA, that countries in this region were already operating in like quite constrained funding environment. With we have no countries that were getting directly supported through PEPFAR or USG funding. So the Global Fund has remained a key donor of HIV responses in the countries for several years now. So in a way that that was helpful, that we didn't get abrupt funding shortage like some of the other countries in other regions did. But now we are at a place where I think it's trickling down to now Global Fund also starting a reprioritization process to align the grant to current financial situations. So I think that's a little bit of uniqueness to the region. But I think what I wanted to also sort of project from my presentation was that even in funding constraints and limitations of stigma and discrimination, successes are possible when there is like good engagement of communities and community-led service delivery. Now, I agree with Beatrice what you said, that we have invested a lot and we cannot let go of those gains. So we need to find ways to raise the advocacy, to get political commitment, to sustain these services. It's not going to be easier. But I think what's really critical is that the communities to raise their voices, get engaged in prioritization processes that are underway, so we can, weigh in on what is critical and essential to be maintained in the face of these challenges. And I think leveraging domestic finances and, the governments to come forward with, stepping up to address these challenges is critical. And in the region, we have seen that some countries have shown very strong political commitments when it comes to viral hepatitis responses, for example. So I think thinking of like what are the ways to leverage that commitment or momentum to also then benefit the HIV responses, I think it's another way to look at it. I think we have to be innovative and smart in terms of how we can get that commitment and leveraging the opportunities that are offered to us. So I think that's a short answer. I'll let other panelists come in.
Excellent. Thank you so much. I don't know if Yvette, would you like to share anything? Please.
Thank you so much, Beatrice. I think from the region in Africa, South Africa, we find ourselves in a very difficult position where some countries really do not contribute that much to not only their HIV budgets, but their health budgets overall. And some people would say South Africa is in a better position, but we are not. The difference is really big. And I think important for us for the last 5 years, we committed to 2030, and I'd like us to challenge ourselves. We committed to 2030 is for the last 5 years. What are we going to do that's going to count? It's important for us to know that for us, we need to prioritize if we want to make an impact and keep to the goal of 2030. So what are the things that we are going to do to ensure that even as our governments struggle to close the gap and the funding gaps, etc., but what can we do as advocates to ensure that we bring the numbers close to an end in 2030? Thank you so much, Beatrice.
Thank you. And I just want to as well to comment on what you said on not allowing the trust on research to be jeopardized. I think this is a major point, as we are all suffering a lot with the cuts in the research enterprise. So it is major in South Africa, but it's spread out. So we are really concerned about what is going on with what will go on with the research networks that we have been affiliated for so many years, and the trust that our study participants will have once this crisis is over. So we need somehow to find a balance and see how best to be ethical with our study participants so that we don't destroy decades of such a strong work that is being done in the different regions with the US research funding. So I have a question here that is directed to Jonah. So for Kenya, are you measuring the increase in HIV infections, increasing viral loads, increasing resistance, and increasing mortality since PEPFAR cuts? This is for Jonah. Is he on?
Yes, thank you. Thank you for the question that I've been asked. Yes, I wish to respond by saying that albeit slowly, I think there is continued measurement of all the parameters that usually we monitor for HIV management response. So in terms of viral load measurement, the country is going on with measurement at the moment. Thank you.
Yeah, would you like to comment as well on the sustainability of the governmental actions after the cuts?
Yes.
How do you
in terms of
envision the sustainability? Yes, thank you. Sorry.
yes. So in terms of the sustainability, I'm saying for the time being, what we have is we are benefiting from there was an extension given in terms of the HRH, Human Resource for Health, up to around September. So as a stopgap measure, what the country is doing is we are continuing with the capacity building of other staff within the facilities so that they can be able to take up the role. That is in terms of the task shifting. When it comes to commodities, at least for the time being, we have adequate commodities. That is the HIV testing products, commodities. We also have adequate the PrEP commodities. When it comes to the VMMC, we also have the commodities that have actually been procured through the Global Fund. So what I could say is for the time being, we have the necessary commodities to continue with the service delivery. And then in terms of policy, we are looking at more of strengthening the community component, the community engagement, so that working with and through the community, we can be able to enhance the service level that is being provided at the county level, and also not to forget about the private sector engagement, because so at the moment we have the private sector engagement framework, which we need to look at how we can be able to operationalize that so that we strengthen the private sector engagement in terms of provision of service. And this not only the care and treatment, but also the prevention services, as well as looking at how to simplify the PrEP delivery so that it can be also provided at the community level. And we are exploring at the new WHO guidance, which provides that we can be able to use the self-test, HIV self-test kit, so that we can either initiate, continue, or re-engage or reinitiate on PrEP. But for as a country, we are looking at being able to use the HIV self-kit to be able to continue on PrEP. And this, we believe, is going to a long way reduce the workload at the facility, which has been necessitated by the increased clients who are visiting the facility, and yet in terms of the HRH, we are having a decline of the human resource for health. Thank you, and over.
Thank you so much, Jonah. That was really good to hear that you are being very thoughtful in all the approaches. So I we have 2 minutes to close, and I will need to pass to Didier. But first of all, I would like to thank you so much for such an incredible webinar. It has been amazing to hear from each of you. I think that we need to do whatever is possible to continue funding the HIV response and being mindful of the sustainability of the actions in this such a meaningful moment where we have these amazing prevention technologies that are becoming available, and hopefully they become available, truly available for everyone in need. So, and we need to be very mindful not to leave anyone behind, because given the current environment, it's very easy to leave behind those most under most vulnerability. So be mindful of the key populations and increase the fight against stigma and discrimination in all actions that are being done. It's the only way that we make possible to sustain the HIV response everywhere. I would like to remind you about the Kigali conference, the IAS 2025 conference that will happen very soon in Kigali, Rwanda, and we hope to have you there, either in presence or virtually. So we really appreciate your participation in our conference. Hope to see everyone there. Thanks again for all the participation and the great comments you had. Thanks for our audience. We had over 400 people with us today, and I pass to Didier for the final word. Thank you.
Okay, merci beaucoup, Béatrice.
Thank you so much, Beatrice. In order to conclude, I would like to give you some information. There will be an evaluation survey that you will see on your screen. You can scan it. We want this feedback. It is important so the IAS Educational Fund can continue to improve its webinar for the future. The link to the survey is also being shared in the chat box. We will send it later. Thank you again, all of you, all the speakers for your participation. As Beatrice said, we are more than 400. There will be a replay of this webinar on the website for IAS. I wish you a very good day, very good evening, and we will see you very, very soon. Thank you very much.
Thank you, everyone.
Thank you. Bye-bye.
Merci. Bye-bye. Thank you.
Gracias.
Bye.
Bye.